Joining us after a long weekend and kind of the start to the holiday season for our fall semester Peptida Pediatric Pulmonology webinar. We're talking today about breathing new life into recruitment, a discussion of the pediatric pulmonary workforce and fellowship recruitment strategies. And we have a great panel this afternoon with 3 panelists with extensive experience and published work on medical education within the field of pediatric pulmonology. We'll start off with Dr. Penina Weiss, for those that I think they're all known to us, but just to give a little background. So Dr. Penina Weiss, professor of pediatrics at Yale University and vice chair of education for the Department of Pediatrics. Dr. Aliva Day, who's an associate professor of pediatrics at Columbia University and immediate past president of Peptida. And Ben Nelson, who's the program director at Mass General and a past recipient of the ATS Pediatric Clinician Educator Award. So we're really happy and thankful to have all of them today share their experiences and their thoughts with us. Sarah?
Yes, welcome everybody. So what will happen today is Dr. Weiss is going to summarize the supply and distribution of the pediatric pulmonary workforce as discussed by the National Academy of Sciences. Then we will move from there to Dr. Day, who's going to talk about evidence-based approaches, recognizing the role of international medical graduates sort of in our workforce. And makes me think about the global mission of taking care of little lungs all over the world, as well as in the United States. And then we will end with Dr. Nelson, who will talk about evidence-based approaches from his own research as well to early recruitment to pediatric pulmonology. Following that wonderful panel, everyone will talk for about 10 minutes. We will do a little activity together. So get your phones ready. We'll be using Poll Everywhere. So there's going to be 4 questions, and we'll have a little bit of discussion after every question, just to get the juices flowing so that hopefully this can start newer discussions and conversations moving into ATS and our other bigger meetings about how to get more pediatric pulmonologists. I initially wanted to title this talk something with the word unicorn in it because we are so rare, and maybe we can become less rare as more people learn about our wonderful field. Without further ado, I will let Dr. Weiss take over.
Okay, well, everybody knows me as Penina, so really happy to be here and to start this off. And I really thought that I'd focus, and thank you so much really to Lara for really guiding this conversation on the national data. And John Cotter has, I think it's 7 steps to affect change. And the first step is to create a sense of urgency. And so I guess that's why I'm going first. So I'm just going to share my screen here. And let's see. Can you guys, oopsie. Sorry. Okay, great. Unusually complicated. I'm using a different computer than usual. So creating a sense of urgency. I'm just going to show you a couple of graphs. And so the first one, as you all know, is really something that begins way more proximal to when we're interviewing fellow applicants. And that's the number of MD graduates who are going into pediatrics that has really been declining in the last 15 years. And Oliva's going to talk about the role of IMG. And so I think it's an important kind of facet to this discussion. So if you look at the total fellowship applications, and this is what was really a hot buzz in 2024. This is pediatric fellowship applications, and you could see that there was a dramatic decrease in 2024 with a little bit of a rebound in 2025. And so the question comes up, is this really just inherent to pediatric fellowships, or fellowships across the board. And unfortunately, as you can see in the other slide, is it's really pediatrics. If you look at all the total fellowship applications, which is really, this is, you know, a lot of internal medicine mixed into this, you could see that they didn't suffer the decrease that we did. And then if you look at pediatric fellowship applicants by subspecialty, and so the subspecialties are below, pulmonary is like second to the last, and then blue is 2023, orange 2024, and then gray is 2025. And you could see that many of the fellowship programs between 2023 and 2024 went down. But notice that the big decrease is in a large part being caused by emergency medicine, because they had one of the largest decreases. And then if you look that there was in many of the other fellowship programs, such as GI that went down, Hem-Onc that went down, they rebounded up this last cycle. And Pulm's kind of puttering along here, you know, with kind of, there's been variability for years, but it didn't see the rebound that some of the other fellowship programs saw. And now we're going to go into some of the finances. And so, you know, kind of talking about what impacts decisions to go into pediatrics and pediatric subspecialties. And this always makes me super sad because on the y-axis is the lifetime earning potential versus the subspecialty, comparing adult in light gray to pediatric in black. And you can see the disparity with pulmonary being in, you know, kind of in the middle here, but a very large disparity between pediatric subspecialties and subspecialists and the adult or internal medicine subspecialists. And then there's this data, which looks at the lifetime earning potential versus recruitment. And this is just pediatric fellowship programs. And this is going to be important when we start thinking about, you know, changing duration of fellowship training, for example. And this came out, I think, in 2022. And what it does, just to orient you, again, is lifetime earning potential. We're going to compare the subspecialties to this red line, which is Gen Peds. So this is a resident who has just graduated and gone into practice. And you can see that the only fellow or subspecialties that actually make more money than the general pediatrician are cardiology, critical care, and neonatology. All the others, and pulmonary is in the middle again. All the others make less money than a general pediatrician. Now, if you start looking at other models, so again, black is kind of, that's the baseline. If you think about eliminating medical school debt, that's going to be in gray. And there's a little bit of an improvement in terms of lifetime earning potential, but very, very modest change. If you start talking about a 2-year fellowship, which is in this thatched, you know, this thatched pattern, or the dots, which is a loan repayment program, then there's a more substantial positive impact in terms of lifetime earning potential. But only emergency medicine actually flips from being negative when compared to general pediatrics, then, you know, otherwise the rest of the subspecialties do well, but in general, not better than a general pediatrician, which is very disheartening considering the training that we all do in the subspecialized practice. And then this is called, I kind of think of this as my silver lining paper, because it actually came out after some of this other data. And this was a paper that was written by individuals that you very well know in the pediatric pulmonary community, including Deborah Boyer. And it looked at the American Board of Pediatrics did a modeling project. And the modeling project was to predict, based on current trends, and workforce needs, where we would be by 2040. And so the part of the, I guess, the goal of this was to really think about some geographic differences. And I really, really liked this diagram from the paper, which looks at the number of subspecialists per 100,000 children. And you could see in dark blue, that's where it's most dense, with some of the numbers actually kind of specified here. Highest was in DC, where it's 8 per 100,000 children. And then the lighter is where there are obviously fewer. Now, if you look at where the fellowship programs are, and you look at their sizes in terms of 1 to 3 filled positions, greater than 3 filled positions, and you see, first of all, where the fellowship programs are located, as well as the size, you can see that the fellowship programs are located, the larger ones, especially in the much more dense areas where they're already subspecialists. And I can say Ben did a really nice study in terms of kind of, looking at the impact of this on recruiting and the success in recruiting of large and small programs. And so what's going to happen? And the reason why I call this my silver lining paper is because it actually looked better than I would have anticipated, is that if one does this modeling, is by 2040, the modeling predicts that there's going to be 36% more of us, which is about a 1.8% increase per year. This is including an assumption that fellows increase by 12%, because what I showed before was ARIS data, but not field data of the programs. And that's very different, since in terms of the number of fellows, there's been an increase over the last 10 years, but it certainly has not kept up in terms of the number going into other subspecialties or the increase in the number of programs that we have. And so the punchline was that Pulm should be able to keep up with the US population growth, again, depending on some of these criteria. And they did a worst case scenario, what happens if fellows decrease by 12.5%, and we still should be able to keep up. But I'm not sure, given our problems with kind of proximal supply in terms of MD graduates going, or other graduates going into pediatrics, that we may actually impact this worse. And this graph just shows that there are different areas that will be seeing larger increases in terms of the number of pulmonologists versus the other ones that kind of have a much more modest increase. And so the NASEM report, which I think Lara alluded to, that came out about a year ago. It's the Future Pediatric Subspecialty Workforce. And, it was based on data that was not as sanguine looking. And so what they came out with is a number of recommendations. The top 2 are more, promote collaboration and effective use of services between pediatric primary care clinicians and subspecialty physicians, reduce financial and payment disincentives. That alludes to, that pay differential between internal medicine and peds, support the physician scientist pathway, and then enhance education, training, recruitment, and retention. And specifically for that last point, to get a little bit more granular on their recommendations, was to review and adjust educational curricula to address the population needs as well as workforce needs, to develop distinct fellowship training pathways, including a 2-year option for those with a focus on clinical care. That garnered a lot of interest/controversy. Improve URIM representation in the workforce, which is much needed. Reform GME funding to have a better proportion of pediatric GME, and increase funding for the Pediatric Specialty Loan Repayment Program, which, as you saw, could have a modest impact in terms of lifetime earning potential. And then what kind of happened based on these recommendations in the study was that AMSPDECT, which is the chairs group, undertook a workforce initiative. And you could see the leaders of practice collaboration, economic strategy, physician scientist, and redesign education. And again, based on the work, there are action teams. So I think it's really important when we think about, well, what can be done about economic strategy, that there's actually a group working on it. So thank you guys very much. Certainly, if there's any questions, can answer now or later.
Thank you so much, Panina. That was fantastic and totally orients all of us. And we were talking about how during ATS, Deborah presented that paper with the modeling, which seemed pretty different from the National Academy report. And so how do we reconcile those two things while also addressing things like reimbursement and length of training and things like that? So really appreciate your time. I think we'll switch and then we'll sort of save the discussion for the end once we've heard from everybody. So our next speaker will be Aliva talking about international medical graduates.
Okay, you see my slides, right? Hello, everyone. Welcome. And thank you for the opportunity to speak on this sort of important topic, recruitment of immigrants in pediatric pulmonology. So my objectives were to recognize the role of international medical graduates, and also known as IMGs, in the pediatric pulmonology trainee workforce, to describe the role of IMGs in the trainee pool in pediatric pulmonary, and describe the challenges faced by IMGs during training and in the job search. So there has been an increased focus on diversity and URIM in recent years, but IMGs also represent a unique group with their own set of issues and challenges. And to be truly inclusive, it is important to pay attention to their cause. I do want to give a disclaimer that I am an international medical graduate myself. And while I was preparing this talk, it was kind of interesting because a lot of the things that have been described as challenges were sort of normal obstacles for me along the way. And I was just able to reconcile and relate to these issues more deeply. So hopefully I can do justice to the topic. And at the end, we can come out with some concrete resources and strategies for program directors to pay attention to the IMG workforce. So who are IMGs? A graduate from a medical school outside the US, Puerto Rico, or Canada is considered an IMG. So they could also be US citizens who completed their medical education outside these regions. So most commonly, students from the Caribbean medical schools are considered as IMGs as well, but they are US citizens, so they have less challenges than the true non-US citizens from international medical schools who would be in the US on one of these different categories for their visa. So it would either be on an H-1B visa or a J-1 visa. So the H-1B actually incurs a cost to the GME, so it's getting less popular and less favorable. So more institutions are moving towards the J-1, which is an exchange student visa program, and it's free to the institutions. But these non-US citizens could also have a green card through other avenues, or they could have an employment authorization card, which allows them to work in the US, and it's easier for them to get subsequent job placements. For the purpose of this talk, we will mainly focus on the non-US citizens, and particularly for the ones who are on a visa. To be eligible for licensure and practice in the US, all IMGs must be certified by the ECFMG and complete a residency training program in the US. And here is data from the AAMC and the ABP that estimates that IMCs really comprise a big, substantial portion of the trainee workforce, as well as future specialist workforce. So up to 35% for adult pulmonary, 48% for critical care medicine, and 30% for pediatric pulmonologists. And here again, there is variation by region. So in some states like Florida and New Jersey, up to 50% pediatricians are supposed to be of IMG background. And over the last decade, there has actually been an increase for pediatrics and pediatric subspecialties. So we're all aware of the emerging knowledge of the importance of a diverse workforce. So diversity in the physician workforce encourages innovation, excellence in medicine, and support for cultural and linguistic barriers to healthcare for patients. Racial and ethnic concordance between a physician and a patient can result in better trust and more use of preventive care by patients, so overall improving patient outcomes. Diversity in the physician workforce is associated with improved patient outcomes and better educational experiences for trainees as well. And many studies have shown enhanced productivity as a result of employing a diverse workforce. So I wanted to share some data from our pediatric pulmonary program directors group. So if you remember, we had employed a survey earlier in the year, which was part of the Guardians of the Lung ATS white paper project by the PEDS Assembly, and that was instituted to division chiefs, as well as a subsection of the study was looking into fellowship training program issues and recruitment, which was sent out to program directors. We had about 21 respondents from program directors, and these are like results. I'm just giving you a preview into some of the responses related to recruitment in PEDS, particularly with focus on the IMGs. So IMG status did not significantly influence interview decisions as per 29% of the PDs. However, it did impact rank list decisions. There were some concerns regarding the ability to assess clinical training and preparedness for fellowship among these IMG applicants per 38% PDs. And funding for these positions presented a challenge, though programs reported finding ways to support the visas, and 46% programs supported J1 and 38% H1B visas. And when we looked at the number of IMGs, I think there was a big range, again, from 0% to up to 100% of trainees in certain programs were from IMG backgrounds. Okay, so challenges that IMGs face starting from before, during, and even after training. So before residency, there's uncertainty of start dates because there could be delays with their visa processing. They have to build competitive resumes because they're competing with the US grads. They often score higher in their USMLE exams. They have to seek for themselves externship opportunities for US hands-on clinical experience to get letters of recommendation. And even then, their chances of securing interviews and matching successfully is actually much lower than US grads. Navigating the US culture has been reported on interviews as one of the biggest challenges that IMGs face, coming from entirely different backgrounds. So they reported things like understanding the housing landscape, even like sending their kids to daycare, understanding how grocery shopping works in the US, even like common American culture, like talking about sports and famous celebrities are things that they really had to get accustomed to and learn to blend into the US system. And then understanding the school system for those who had kids. Adaptation to the US GME and healthcare landscape was rated next. So most of these countries have a sort of doctor-centered approach to patient care, where the doctor is like at the top of the hierarchy and patients have to listen to anything that the physician recommends. So it's a huge culture shock to come to the US and understand the intricacies of a patient-centered approach where you have to listen and involve the patient in your decision-making. Most of these trainees were used to working long hours, but had trouble adapting to the administrative burden, paperwork, chart documentation, working within multidisciplinary teams, as well as understanding the insurance complexities in the US healthcare system. So communication skills is always a challenge working in interdisciplinary teams, but also depending on their English proficiency, but other things such as even changes in the speech, tone, voice inflections, adjusting to American accent, and then skills around delivering bad news and encountering challenging patient encounters are things that they had to really learn. Racial discrimination was also reported. Most IMGs reported experiencing harassment, not just from patients, but also attending faculty, residents, and nurses. And these ranged from racial slurs, favoritism, malicious gossip, aggressions, and so on. And then furthermore, they would rarely report these incidents because they're often not aware of policies or they have a fear of retaliation. So research experience is another area we should be cognizant of because many may not have had previous lab or undergraduate research experience, particularly for the non-US citizens, and they may not be eligible for NIH training grants if they're on a visa. The CFF awards did expand eligibility to include visa holders in 2022. So that really allowed a lot of these trainees to apply for this grant. They often are in emotional distress due to all their challenges, communication issues, feeling of going backward in the medical education hierarchy. They don't have family support, and all the frustration of being in a foreign land and this feeling of not being able to contribute to the problems in their own countries that fuel their migration. Though they don't have loans, there are financial difficulties for IMDs as well, because they're often from low and middle income countries. They have to invest substantially for their travel, migration from their home country, and then seeking all those opportunities to make their resumes competitive by taking externships, additional courses, and trying to get letters of recommendation. And then after their training, now they need to find a job that will sponsor their permanent migration process and their petition for immigration. So that is slightly different depending on which visa they're holding. So post-training challenges, like I said, so there's two different pathways depending on the visa that they hold. So for the for the J1 visa holders, so J1 is considered a non-immigrant visa, which has a limit for 7 years. And the expectation is at the end of these 7 years, you have to return back to your home country for a 2-year period for a mandatory physical presence requirement in your home country. If you want to avoid that, then there is a way out by applying for a waiver, which means that you will agree to work in an underserved area in the US. And then there are different designations and categories based on whether they're federal government programs or funded by state public health departments. So the state program is known as the Conrad 30 program because they sponsor about 30 positions per state. So it's like about 1,000 positions for the whole country that these trainees are recruited into. And very few are actually in academic centers, about 3 to 5 per state. So majority of these positions are in rural healthcare communities, which have difficulties recruiting physicians otherwise. So as a result of this waiver process, they're able to get physicians to work in those communities. So this benefits both the underserved communities as well as the ones seeking for a waiver and eliminating the requirement for returning back to their home country. But then at the end of this 3-year period, they're often behind in their academic and faculty development process as they've been working in a rural area. So to come back to academics is challenging, and they're often underrepresented in academic research, med ed, and administrative positions. Here's a map of these underserved areas. So they're called, they're called health professional shortage areas. And this shows you in green the non-metro areas and in blue the metro areas. So the darker the color, the higher the score for that area to recruit, to have challenges with recruiting their own physicians and expanding opportunities to the J1 waiver holders. So for H1 holders, it's slightly different. It actually requires a higher cost. So depending on the cost of sponsorship, institutions can make decisions on whether they want to sponsor this visa or not. It also has a limit of 6 years after which they would have to, by which time they would have to apply for their permanent migration process. And this is the reason it's also difficult after a 3-year residency program for applicants to make a decision whether they want to pursue fellowship, which will sort of reach the end of their term limit on H1 and make it harder for them to get a sponsorship for their green card. So they require an employer to sponsor their green card within by the end of that 6-year period. So if they do go into fellowship, they actually have to pursue alternate pathways known as these other categories. They're called either National Interest Waiver, NIW, or an Extraordinary Ability Candidate pathway where they have to pay tons of money as well as try to get elaborate recommendation letters and proof of their being an extraordinary candidate by showing immense scholarly work and publications. So it's not all gloom. There are some advantages. So they often have a lot of clinical experience and medical knowledge, having trained in environments that don't have phlebotomy support or are in high volume clinical settings, and often master skills of efficiency and organization by the time they're entering training. And just for perspective, a doctor-patient ratio in a country like India is like 1 in 3,000, whereas in Africa, it could be in some regions a ratio of 1 to 50,000 patients. In the US, it's about 1 to 400. So you can imagine they've had a lot of high volume training and it makes things easier for them. IMGs have shown to score higher in site exams than US med grads. They've held more advanced degrees and have had added scholarly publications, and which has been linked to better patient outcomes. They are crucial in closing some cultural and language gaps. So their varied and diverse cultural experience can cater to specific diverse populations. They could have other unique life experiences and rich backgrounds, such as experience with some rare infectious disease. If there is an outbreak like that, they could offer expertise in those situations. So they are an integral part of both the general pediatric and the pediatric subspecialty workforces and can play a role in addressing current or future shortages. However, sometimes there are concerns with visa regulations, immigration reforms, travel bans could impose potential threats to a decrease in the number of IMG applicants. So some resources and strategies that programs can employ, there have been attempts to develop instruments to help IMGs in their transition process. These are some resources I have cited here that are available on MedEd portal. There's this acculturation toolkit, which I think was really cool. It gives you some strategies for employing discussions and didactics and role play situations that you could use on your trainees and help them achieve better understanding of the US culture, to shift from a doctor-centered to a more patient-centered care, to improve their communication skills, confidence, and so on. There's also workshops available for chart documentation and for asking difficult questions. So I will just lastly end with some other strategies for program directors and division chiefs to know your institutional rules for which visas are offered and sponsored, to communicate with your IMG trainees frequently, to understand what's going on in their lives and to support them adequately, to include workshops during onboarding and training, to improve their competencies and clinical skills as necessary, develop a customized scholarly activity plan, recognizing that they may not be able to apply for certain grants or funding, and you customize their opportunities accordingly. Seek out additional degree opportunities to strengthen their resumes. Have a knowledge of their timeline for job search, like the J1s often have to begin very early in their third years, which could compete with their other demands with research and scholarly productivity and could distract their attention. So it's important for program directors to be aware of that. Support them with letters, additional publications, and then seek solutions for recruitment and retention of your IMG faculty. Thank you.
Thank you, Aviva. That was really comprehensive, a great summary of all the challenges that IMGs have during training and after. I'll just add that I think some institutions and even states are looking to kind of make it easier, including Tennessee passing a recent law to allow IMGs to be certified even without having like a residency, so they don't have to repeat their residencies here. But thank you so much. And we'll pass it on to Ben since we're a little behind schedule.
All right. Hi, everyone. Good to see you. There we go. So let's see, a number of years ago when Panino was actually the president of Peptida, we were trying to ask the question of why trainees were going into pediatric pulmonary fellowships and why they were pursuing training. And we all kind of had our own ideas. We'd all been through it, but there's really no data. And we thought it would be a good idea to gather some qualitative data to get a better sense of what's drawing trainees to our subspecialty, so that then we could continue to enforce what we were doing well in terms of recruitment, but then also change what maybe we weren't doing so well. And solidify some of our preconceptions, but then also learn maybe there's things out there that we didn't realize. And so we took advantage of the ATS. So this is back in 2019, pre-pandemic, and we had this wonderful, with our partnership with ATS, we had a wonderful opportunity to do focus groups with first and second year residents, as well as third year residents at the resident boot camp and current fellows. And we talked to both fellows in pulmonary as well as pediatric ICU. And I wanted to run through you guys with you guys some of the themes and quotes that we learned. Some of it was fascinating, and also then how to think about it. And really, what's most important is how to operationalize this, especially with the new ACGME requirements coming into effect next year, which actually might potentially be beneficial for us. So some of the stuff is intuitive, but I thought it was important to just kind of lay out the background here. So attractive aspects of pediatric pulmonology draw trainees to the field. Well, that's pretty obvious, but what are those? You can see on the left here some of the things that the trainees routinely said, from physiology to bronchoscopy and longitudinal relationships. One fellow said they didn't even consider pulmonary medicine until they went to an actual bronch. And so it was something they hadn't experienced, and that pulled them into the field. We found, I think we knew this, but I don't think I was really attuned to this, that exposure to the breadth and the depth of the scope of the field was actually quite limited at the time. For most trainees, they said that their pulmonary experience was really an inpatient rotation, and it consisted a lot of places of patients on chronic ventilators, patients who have rare diseases, and one person said that people actually dreaded being on the pulmonary elective for that reason, where they didn't really get to experience what it's truly like to be a pediatric pulmonologist. We all do inpatient time, but for most of us, it's not the majority of what we do. And then lack of exposure led to a lot of misconceptions that it's pulmonary means you're taking care of sick kids with rare things. There's not much you can do to improve their quality of life. And they really don't understand, they really didn't understand what we did. Mentorship is key. Mentorship's always key. We always talk about it, but I'll talk about a little bit later some actual recommendations to make that a little bit more tangible. But specifically, these trainees talked about faculty explaining the field to them and actively recruiting them. This one's important. This has been borne out in a couple of studies now that decisions surrounding fellowship selection tend to occur early in the second year, maybe even earlier in the first year. And for a lot of trainees, their first exposure to pulmonary elective might not be till the end of their second year or even in their third year, which is too late. This one resident said to me that she had been completely set on doing an endocrine fellowship, but then she had the opportunity to do a pulmonary rotation, fell in love with it, and it was during intern year, so she had plenty of time to kind of switch gears. This comes back to the age-old question of flexibility in the fellowship. And trainees definitely thought there might be increased interest if there was increased flexibility or the potential to pair with a sleep medicine fellowship. We got both sides of the coin. Someone said, you know, I don't really think it's worthwhile to make everyone use a year to a year or 1.5 to 2 years of their lives to do something that they really have no interest in doing. And on the flip side, someone said, I thought I would hate research going into it, but ended up really liking it, and they were currently applying for funding and wanted to make it their career. At least in our cohort, financial considerations were not the driving factor in decision making. They kind of said to me, look, you know, we've already made a decision to forego a lot of earnings by choosing pediatrics to begin with, because these are all people who've already either in pediatric residency or in pediatric fellowship already. So they've already kind of made that choice to forego some future earnings. And they felt that most of them actually knew that general peds compared to peds palm made more money, but they felt like there were such different jobs. They really were apples and oranges comparing gen peds to a pediatric subspecialty. So for at least for this small cohort, financial considerations weren't really at the forefront. So then we asked ourselves, well, how do we take this data and really make sense of it? And so we grounded our data in the social cognitive career theory. So this is a theory that looks at the interplay between the individual, their background, their environment, their supports and barriers, and how specific learning experiences then shape their interests, which ultimately influence their career decisions. And so specifically applying to our data to this, I won't go through all this in detail, but we basically learned that if you expose residents to specific learning experiences that do two things: one, increase their self-efficacy, and two, put them in a situation where they're going to have favorable outcomes, then you can really harness an interest in pulmonary medicine and kind of push them along the path to applying for fellowship. And some of these specifics are what I'm going to outline in these next few slides here. So we're very intentional about the scheduling of the elective. After we did this data, I went to our residency directors and talked to them about the need to give residents the option of doing a pulmonary elective during their first year, which they really didn't have much of an opportunity to do. And I showed them this data as well as other data showing that, you know, it's really important in helping them make their career decisions. You want to provide a broad exposure to the field. You want to expose them to inpatient, outpatient medicine, bronchoscopy, research, all QI, all sorts of things that we're doing on a day-to-day basis. And in order to do that, program directors can't be the one who are the only ones interfacing with the trainees. You need your faculty members to take charge as well, and that takes faculty development. And so teaching them how excuse me, to teach in today's clinical learning environment, how to be advisors or coaches or mentors or sponsors, and that definitely takes some intentionality. Learning experiences, they have to be hands-on. Even I know that electives are oftentimes broken up, so it's hard to follow patients longitudinally, but even if it's just for one day, have them see the patient on their own and present to you, whether that's inpatient or outpatient. When you're doing bronchoscopy, if someone's never been in the bronch suite before, you're not going to have them do the whole procedure, but they can get their hands on the scope even at the end. Just to pull the scope out can be really exciting for trainees and really get them involved. You really do want to provide a variety in clinical settings, not just the inpatient unit, so it takes more effort and more scheduling. And some trainees told me that their pulmonary elective time was really just inpatient time. So really making sure they have dedicated time for a pulmonary training or elective experience is important. And then I do this all the time, is that I try to identify trainees early in the training, so first and second year, who might be interested in the field. And I tell them about opportunities to go to the CF conference, to the ATS conference in the spring. And data has shown that if you're able to get them to go to one of those two conferences, it really, a lot of those trainees will end up applying for fellowship. And so each year I send out, as soon as the applications open, I send it out to all the residents, and I tell them about it, even if they haven't expressed interest to me. I try to meet with every resident before they start the elective, and they do a 2-week block at our institution. And I really tailor their elective to what their goals are. Some people have different experiences. Some people want more inpatient. Some people want more outpatient. Some people want to be involved in some scholarly work. Some people have a specific disease process they want to follow. So maybe they want exposure to a sleep clinic or an ILD or genetics clinic or something like that. So I always bring them in at first, and then I build in flexibility into the schedule because I don't need them to do the work. It's really how can I best help them achieve their goals, and then they feel more empowered and more involved in the elective process. We talked about active participation. And then I really encourage my faculty, especially when they're on service and have some clinics blocked, to go to morning report or go to rounds and be a presence, even if it's just one time and you only say a couple things during the conference. Just being present and talking about pulmonary medicine can really go a long way in that role modeling. And I would just say end by saying that if your residency programs right now are in the process of redesigning their curriculum based on the new requirements starting next year, now is a great opportunity to talk to the residency program directors about how you can get more trainees exposed, and especially early on, to your electives.
Thank you, Ben. That was great. Now we've got all the tools and all the things we can do. So we are going to turn to the interactive portion of our session today. So everybody get your phones out, and if you're feeling brave, turn your camera on. And I'm going to share my screen because it is time for Poll Everywhere. Can everyone see that? All right, so you have two options. You can send a text to Laura Bichet 063 to 22333, or just use the QR code, which did work earlier. So we're gonna have to commit to one strategy for this question. So commit to the strategy that has been most helpful for you in recruiting fellows. And if you pick other, which you are welcome to do, we will ask you to share what that other is. So we're gonna wait a little while. There's about 21, 22 of you. So when a good chunk of you have answered, we'll take a look at the results for this question. And then my hope is we can discuss a little bit more about what has worked, what hasn't worked. You've got Ben, Aliva, and Penina here as well to talk about these techniques and different ideas.
While we're waiting, I had a question for Penina. When looking at no debt versus loan repayment programs, like what is the main difference? Because you would think if you have no debt, then you don't need loans, but.
Yeah, so sorry, I should have specified that. That's actually med student debt. And so like for those who may go to med school where the tuition is waived versus those who get to pay back their loans from college, med school. So it's kind of just a wider net.
Thank you.
That's a good question. All right, we're at 14. That's pretty good. Are we ready? You ready to see what everybody said? All right, let's take a look. Okay, so the subspecialty rotations, that's consistent with Ben's study, one-on-one mentorship, and then actually having a project. Anybody want to be brave and any comments, any thoughts about this? Anything surprising in this list of techniques?
Then when you reached out to the program director for residency, were you able to make changes or headway? I mean, I imagine everybody's kind of in the same boat as far as different specialties, or if anybody else have had similar discussions.
Are you talking about in the past, Tanya, or for the upcoming changes next year?
Upcoming changes, yeah.
For the upcoming changes, a little bit. You know, when I was talking with them, I basically told them what it would be, what we would love to see happen, just more exposure to our clinics and our faculty, and they should be coming back to us soon with, you know, kind of what they're going to be doing. So I don't have anything else to say updates for that yet, though.
I think, Tom, did you have comments?
Yeah, so based on kind of Ben's suggestions there, it is like I do feel like we now have an opportunity to have those really early experiences, and hopefully at your institutions, you're all taking advantage of the fact that the core pediatrics residency requirements are going to be very different in 2025, and we're using that to our advantage by actually mandating an early pulmonary elective, since our residents won't be on the pulmonary service anymore. So this is actually, we're using this, we're being opportunistic here and making every intern rotate through pulmonary on the consult service for a couple of weeks. So those are excellent suggestions, and it just so happens that now we have an opportunity to implement those a little bit easier.
That's a great point. Say like, yeah, take the residents off our service, but they need to come in and rotate with us. That's awesome.
I think it's also important to make the point that, respiratory complications are the leading cause for hospitalizations in children. And if they miss out on pulmonary education, even if they don't do pulmonology, like they go into general peds, it's so important to train in respiratory care. So even just from that perspective, you should, have these discussions with program leadership.
I think also taking Ben's suggestions into account, making it a rotation that the scope of pediatric pulmonology can be built into these electives and not just ending up in consult service or inpatient some other, in other ways.
Yeah, and I would say one thing I forgot to mention is that we've compiled a list of potential scholarly activities that trainees can get involved with when they rotate through. Some are really short, some are more longitudinal, some are real peripheral, and ongoing projects. And I always send that to the trainees prior to them starting the rotation. And some take me up on it and want to get involved in something, and some don't, and that's totally fine. But at least they have the opportunity, because I find that a lot of trainees want to get involved in a project, but they don't really know how to go about doing it.
Can I add another point? PRDS is 0%, which is a little shocking. I wanted to ask maybe someone from the ATS if we are tracking the outcomes after PRDS attendance, how many of those trainees are going into fellowships?
Yeah, it's Lauren. My understanding is that we are doing that tracking. I can check with Liz and get that for you all, but that's something that we do.
It's very high, Aliva. When I looked at it a number of years ago, after the first couple of years, it's definitely very high. But I guess I wasn't really interpreting the question in that sense. I was more interpreting in how I was getting fellows to my program as opposed to the field. So I think I was thinking about it a little bit differently. But the PRDS is great opportunity.
Which I think is a good segue to the next.
All right. So now that's the last question. The next question is, which recruitment strategies would you be interested in developing to attract new pediatric pulmonary fellows? So this can be how we can support all of our pediatric residents kind of nationally.
While we're waiting, I guess another question I had is, we're looking at long-term having enough fellows nationally according to projections, but does everybody think that currently we have a supply that satisfies the demand? Because even if we increase it or maintain stability, is that still enough? Or are we at risk of a lot of the things that we do, other subspecialties kind of overlap with us, kind of taking over, including bronchoscopies, truthfully. I mean, there are other specialties that are looking into that just because they don't have enough pediatric pulmonologists that are available.
I
Okay.
can speak to my experience. I always feel like I would love more fellows. I feel like there is the volume, there are the opportunities. You know, there's not enough. To me, it often feels there's not enough of us. And at least in my institution, if someone refers a child for a pediatric pulmonologist, the average wait is 9 months right now in Los Angeles, which is really, to be for a toddler with asthma or whatever, that feels too long. So just like you said, Tanya, to me, it feels like there's not enough of us now. And even if it stays that way, can't we change that and make it better?
Yeah, I totally agree with you, Lara. That's exactly what I was going to say, is that for us, it's also a 9-month waiting list. And I'm also super worried that, you know, even with the projections based on the ABP workforce study, that the impact in terms of recruiting UME into pediatric residency programs is really going to impact us. Like, that's actually what I'm really concerned about. You know, and the truth is we haven't grown as much as other subspecialties.
Totally agree. There's some great thoughts in the chat here too. Tom, your point about combining training programs. We have the AIR program that combines pulm and sleep, but that's another thought. Critical care, I know, is few and far in between, but like every couple of years, I'll get somebody emailing me saying, I want to do critical care. But neonatology is a great idea. Yeah, I totally agree with all those things.
Yeah. And the issue is it can be done now. It just takes more years than on the adult side, but that's pretty much, you know, that issue is in terms of the requirement for scholarly training. And so you could do it. It just takes 5 years instead of 3 years that it might take in internal medicine.
Great. So let's take a look at how everybody responded. A lot of people, just like Annaleva, you made, and then the PRDS is so critical for getting interest in here. The online elective curriculum for pediatric pulmonology, I think, would be wonderful. Levi, I know we'll give updates on that at our next national meeting. Pre-clerkship education, and then I think Tom had mentioned, who said they entered other? No, it was someone else.
Well, there's a comment in the chat about pediatric.
Yeah, so interest group is a great idea. Yeah, that's a wonderful thought as well. That's great. All right, in the interest of time, we're going to go to the next question, which is the big one. All right, it's one big one. These are all big questions. But given everything we have learned today so far, how long do you think pediatric pulmonary fellowship should be? And you got to commit. If you put other, please tell us what you put for other. Should it be 3 years with a research requirement? Should it be 2 years, but with a research requirement as well? So everything we do in 3 years squished into 2. 2 years without a research requirement, 2 years just clinical, or 2 years with an optional 3rd year to do something else. So it could be research, could be, you know, QI, get your master's. That was supposed to say further subspecialty training like pulmonary hypertension or sleep or something else. And then other. Oh, and I see lots of people voted already. We're already 11, 12. Amazing. I think we're doing pretty well. To be respectful of everyone's time. Okay, 13. That's pretty good. I'm going to take a look at the responses. You ready? Okay. All right. We have some people who think we can squish everything into 2 years. Some people feel like it should be similar to the way it is now. And then the majority of people thinking about 2 years with an optional 3rd year. Any thoughts, any comments, any strong feelings about this?
I think the adults are doing this, and I understand, you know, the feeling about doing research and missing out on that opportunity if we don't keep it as part of the training requirement. But giving them the option, I think, really sounds like the best option to me. Get your training done for those who want to just learn pulmonary and practice, and then if you want the additional experience, you're able to build that in. And with, like, sounds like you're giving them a lot of different options here. So I think that's the icing on the cake, right?
Which goes along with Ben's, you know, findings too, and what fellows or residents were kind of wishing for. Tom.
I've found that for some reason, the general tone in general pediatrics residency programs is that there's just not a whole lot of focus on research. And I don't know if this is specific to our institution or nationwide, but general pediatrics resident, core pediatrics residents are just not getting really great research experience. And so therefore, most of our applicants really have very little experience or interest in doing research at all. And so 3 years for the vast majority of our applicants, including a research component, seems a little bit forced on these people who don't really have a whole lot of interest. We get maybe 15% of our applicants with a really serious pathway towards a physician scientist career, but that's the small minority. The vast majority are forced into projects they really don't really want to be doing. So I think the 2-year option is obviously with a third year, optional third year for research, if you want to do it, would really improve interest in applicants. I foresee a very substantial increase in applications if we offer 2 years. Then you go on to a faculty position, get a faculty salary for people who really want to just have a clinician educator career. I think there's been a lot of papers on this, but we've been kind of moving in this direction for many years. It might be time to kind of do something drastic, do something kind of crazy.
I think that's a
So,
really interesting thought. Go ahead, Penina. Sorry.
Yeah, so I actually so firmly believed in that, Tom, for so many years. As vice chair of education, the things that are concerning me now is that I don't know how we would pay for that third year. So if you have, whereas right now we're guaranteed in our institution by the hospital funding for 3 years, if the ACGME or we cut it to 2 years, other than a T32, I don't know how I would pay for those individuals, including especially those that are going to be CEs, clinician educators. So that's that's actually like giving me conniptions, though. I actually do believe exactly what you said, Tom, about the majority of, the applicants who come to our program.
I think it also brings forth, as Tom put, that third year, whether it would be completely doing, research, or could they, be part of the workforce, and maybe that way get paid, in a different way, or have funding.
Yeah, we actually do that in our institution too. And the issue is they have to do so much clinical work in order to support their salary. So it's like one of these things that actually I really believe is the right thing to do. I'm just worried about these unintended consequences.
It would also decrease the number of positions, number of fellows you have at a time. If you're taking one per year for 2 years, you'd have 2 fellows at a time. The only way to go around that is to increase the number of positions then. So, I mean, yeah, I think that will require.
Yeah. And the other thing is I'll just be devil's advocate because I've been in discussions with the American Board of Pediatrics, especially since that NASM study came out. We've always had the opportunity to do this. It lands with our subspecialty organization. Like Peptida has never agreed, and the last time we surveyed the fellowship program directors, I think it was 45% that were in favor, and that was like 2019, 2020. But we've always had the opportunity to do it. There's never been consensus. And in addition to that, we would need consensus from probably the division directors. It has to be really the subspecialty. And we've never been able to do that because of the concerns about the impact on the physician scientist pathway also. And those who, like Ben described, learned about research and then loved it during their fellowship. But I think it would be really useful to have a vote in Peptida just to see where the Peptida fellowship program directors are.
So it was included as one of the questions in that Guardians of the Lung survey, and they're actually writing up the report now, but I can share that it was about 50 to 60% from division chiefs and program directors that were favoring a 2-year. So maybe we're moving very slowly in that
I was going to say from
Higher than-
49% in 2000 or 45% to 50. It's like, yeah, very similar data.
See a raised hand.
Hey, this is Paco. So I'm part of the sub-board of Pediatric Pulmonary at the ABP, and I agree. I mean, I don't think we're going to get in agreement. We have this conversation this February, and there were very strong feelings about the 2-year, mainly about research, because then I know that it's not that pediatric pulmonology are doing like hardcore research. There is just a few institutions where, we all know that there's a lot of research. A lot of times it's just mainly retrospective data and things like that the fellows are involved. But if you take that away, then I don't see how this is going to be funded. I mean, there's not going to be enough money. There's a lot of issues with the healthcare systems that they're restricting the amount of money that is coming through any program. And that's also reflected on the survey that we all answered recently, right? Like for like medical directorships and everything. So just fighting for money to support another year of either 1 or 2 fellows. The concern that is just going to disappear. So there's not going to be more research. And if you have like US medical students that have like $250,000 on like loans, they're going to go straight for like, just do the clinical care and go straight to work. So I think that that's going to have a huge impact on the kind of like the physician scientist pathway, unless there is support and funding from other areas. And honestly, again, like I really appreciate all of these and see the answers, but at least from my perspective, we all of us, we've been doing some of these over the last 10 years or so, or even more than that, right? And still the pulmonary workforce is still coming down. It's not like going up. So at the end of the day, you still think there's an issue with funding, is an issue with like, reimbursement, like higher pay for pediatric pulmonologists. The adult pediatric pulmonary and critical care, their base salary when they start is like sometimes twice of what the pediatric pulmonologists will do, or even more than that. So we just need to try to be innovative, but at the end, I think that we need to push for like some long-term changes. Otherwise, I'm really, really concerned about our field.
A really good point. Makes me wonder, maybe there should be some institutions with a 3-year fellowship that have T32s and have a lot of funding and have a lot of our funded attendings, and then other fellowships that are more clinically based that are 2 years. How would that impact your match? I don't know, I'm just processing. But because I do feel that also some institutions are more primed for fellows to be successful in research, and other institutions are more clinically based. They're the star, and there's fewer R01 funded attendings. I don't know how you make that criteria. I was going to do a question, but I know it's 1:10, so maybe I'll let Penina close us out. And I
Oh no, I wanted to do something positive. So let me quick. Yes, I mean, and so I just like we talk about physician scientists, I just think we also need to bear in mind most of us, or many of us, who are clinician educators and got here because of, the support that we received for scholarly activity. And so I just think it's important, whatever we come up with, to include that. And just remember, the clinician educators are not straight, clinicians. So I'm going to turn it to you in terms of being super positive in closing.
You're totally right. Well, I'm opening this up for a word cloud for us to talk about emerging fields, but someone said, good luck everyone on Wednesday, which I love. So you guys are able to write on this word cloud whatever you want, and we'll send out the word cloud to everyone. And Dr. Perez, did you have another question? Oh, your hand is up, still up, but please add another comment.
No,
sorry.
Everybody.
Thank you, everyone. Really appreciate it.
Thank you.
Thank you, guys. This was a great discussion.
Thank you, Pedina, Leva.
Thank you.
Oh, somebody put global health. That's interesting too.
I love word clouds. I'm just still writing.
Yeah, me too. I was going to wait till it stops moving. Let's jump off because it's so interesting.
I
I
love
think
it.
transition of care is a really important one.
Great. That's great. I love it. I will send this out to everybody. Thank you. Thank
All
you. Thank you so much, Penina, Leva, Tanya, and thank
Yeah.
you. It's great to see you all.
Yeah, you
Yeah,
guys led
thank you.
this beautifully. Thanks so much, Lara and Tanya.
Well, it was fun.
Bye. Have a great rest of your week.
Yeah.